So I think now we can start. Please, قطر الندى, start.
Yes, دكتور مصطفى. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening, everyone. Welcome again to the educational webinar series organized by the Iraqi Stroke Network. All our webinars are endorsed by the MENA Stroke Organization. This is our 18th educational webinar. Today's session focuses on a cornerstone of effective stroke care, the stroke unit. Evidence shows that patients treated in dedicated stroke units have significantly better outcomes with higher survival rates, faster recovery, and reduced disability. Building a stroke unit is not just about infrastructures, it is about teamwork, protocols, commitment to organize timely care. We are honored to be joined by Dr. Ivy Sebastian, an interventional expert with rich experience in developing stroke systems across various settings. We look forward to learning from her insights and applying them to improve stroke care in Iraq and the region. Thank you for being with us. My name is Dr. Qatr Samir Alash, a neurologist at Dmaghiة Teaching Hospital in Iraq, of course. And thank you so much. Now over to a leader of the Q&A section, Dr. Mardin Ali.
Good evening, everyone. My name is Mardin Abdulkareem. I am a neurology resident at Shar Teaching Hospital in the city of Sulaymaniyah. Tonight, I will lead the Q&A session at the end of Dr. Ivy Sebastian's lecture. So please, if you have any questions, put them in the chat box and I will read them aloud to the speaker. And if anyone wants to speak, please press the raise hand button. Thank you very much.
Thank you, Dr. Mardin. It was supposed that Dr. Abbas Fadheel, an interventional neurologist at Al-Basra, Iraq, will join us at this webinar panelist, but for emergency situation, he is not here today. Tonight, I am honored to introduce Dr. Ivy Sebastian, a neurologist, educator, and passionate stroke researcher. Dr. Sebastian is currently an assistant professor of neurology at Christian Medical College and Hospital, where her career began with a deep commitment to service and equitable healthcare. After completing her MBBS from CMC, she spent 2 years at a mission hospital on the Indo-Pak border, working with underserved communities. Her interest in stroke was sparked during her postgraduate training and developed through her involvement in landmark ATTEND trial, India's first multi-center study on caregiver-based stroke rehabilitation. Since then, she has contributed to the national and international stroke research, collaborated with WHO CRO and received the Young Investigator Award at the European Stroke Organization Conference. Today, she will be speaking on a topic she is truly passionate about: how to set up a stroke unit, an essential component in improving stroke care in resource-limited settings. Dr. Ivy Sebastian, the word is yours now.
Thank you so much for this kind introduction. I will just share my slides. My slides with you? Yeah. Okay.
Yes, it's visible.
Okay, so good evening to everyone. It is 9 o'clock here in India, and thank you all for joining. So my topic today would be how to set up a stroke unit, and we will talk about a little bit of evidence-based interventions that have been shown to be effective in stroke unit care. We will look at what is a stroke unit, what are the different types of stroke units, what kind of staffing and training is required to set up a stroke unit. And then most importantly, we will look at what are the management protocols that we need to have in a stroke unit. So a stroke unit is simply any dedicated area within the hospital where stroke patients are managed by a coordinated multidisciplinary team which specializes in stroke management. Simply speaking, you need to identify any geographical area within the hospital which is just dedicated for stroke patients or TIA patients with a team which is also specializing in stroke management, which naturally would involve either stroke physicians or neurologists, stroke nurses, and the rehabilitation team, which includes physiotherapists, occupational therapists, speech and language pathologists, and so on. So this provision for specialized stroke services in association with protocols and standard operating procedures within a dedicated geographical area, that whole concept is what is known as a stroke unit. Now, it has been shown that setting up a stroke unit has been shown, has evidence now to show that it can reduce death, disability, and decrease the hospitalization after, the length of hospitalization after acute stroke. So why are stroke units effective, one would think. So if you look at all the available treatments that we have for stroke care right now, although we have now reached into the endovascular thrombectomy era, but or even the or intravenous thrombolysis, but still we do not yet have an inexpensive drug that can be given during the acute phase. First of all, IV thrombolysis is quite expensive, still not easily available or accessible in many regions of the world. And even if it is available, the efficacy is only around 30 to 40%. If we look at endovascular thrombectomy, the efficacy is much higher. It is around 70 to 80%. But again, it is even less accessible to everybody. So until such a treatment that is easily available and accessible to everybody around the world, we are still much of the care after stroke, the treatment after stroke, will continue to rely on non-drug treatments such as stroke unit care and rehabilitation interventions. And it has been shown that if you have a dedicated care of a stroke patient in a stroke unit, it is one of the most effective, cost-effective interventions in the stroke care continuum. And like I mentioned earlier, because of this focused attention on stroke care specifics and a team approach, it has been seen that factors that worsen outcome become fewer. There is earlier detection and treatment of complications. There is earlier implementation of secondary prevention strategies and earlier institution of rehabilitation. And therefore, the patients who've been cared for in a stroke unit are more likely to be alive, to go back home and to become independent in looking after themselves 1 year after stroke. So this was the Cochrane review by the Stroke Unit Trialist Collaboration, and they looked at a network meta-analysis across 29 trials and almost 6,000 participants, and they found that people with stroke who received organized inpatient care, or in other words, stroke unit care, they did have the benefits of being likely to be more likely to be alive, living at home and independent and looking after themselves 1 year after stroke. So what about in LMICs? Now, all of the evidence that we do have about stroke unit care and dedicated stroke care, this all comes from high-income countries. But what about low and middle-income countries such as ours? So in low-resource settings, the key challenge that we face is that we do not have adequate numbers of skilled staff. There is a lack of basic infrastructure, is not fully available everywhere. The cost associated with providing the treatment is, of course, one big challenge which we all face. It is not necessary that everybody would, all regions would have a stroke champion. And more importantly, the concept of integrating stroke unit into service development programs at the national or the regional level also becomes an issue when it comes to LMICs. Now, looking at this, this was a paper by Dr. Pandian and Dr. Langhorn, looking at the applicability of stroke unit care to low and middle income countries. And they found that although substantial challenges are present, but the potential gains from these developments of a stroke unit care are significant. So they looked at studies across 5 low-income country, low-middle-income country areas, comparing stroke care in a discrete stroke care ward, and when they compared it with conventional care, they found that across all the 5 LMICs, statistically significant lower death rates were found in the stroke unit group, as you can see in this forest plot. So now coming to how do we organize a stroke unit in LMIC? So what do we need? We need to identify a geographical area within the hospital, which we can say that this is exclusively going to be for stroke patients. So you need to set apart maybe 4 to 6 beds as stroke beds. Basic monitoring equipment like an ECG monitoring availability, blood pressure monitoring, saturation, glucometer for sugar monitoring, and infusion pumps need to be available. There needs to be a permanent immediate access to an ICU setting in case any patient in the stroke unit worsens. And of course, there needs to be a rehabilitation area within the ward, preferably if there are corridors and accessible stairs, because those again can be used as rehabilitation equipment as in how the patients are taken through the process of rehabilitation. So that was what we need mainly for infrastructure. Diagnostic infrastructure wise, we would need some access to a neuroimaging facility, either a CT scan or an MRI. And if there is availability of CT or MR angiography, that is also very good. However, if that is not available, then you can always rely on duplex ultrasound for carotid ultrasound for looking at the vessels. Brain imaging has to be performed within 30 minutes of admission. So door to CT or door to MRI should be within 30 minutes as soon as you set up a stroke unit care system within your hospital. Every patient must have a 12-lead ECG. Echocardiography, there should be availability for that during the working hours across all 7 days in a week. And urgent emergency laboratory results like platelet counts and PT-INR should be available 24/7, and the availability should be within 20 minutes. So there needs to be at least an emergency laboratory setting where basic emergency blood investigations, if needed, can be attained. If you look at staffing and personnel, so we need to have at least this was what was recommended for a stroke unit with 10 beds. So both off duty and on duty included at least 10 nursing staff. So we are looking at 1 nurse per maybe 2 to 3 beds. That's what we're looking at. And then because it is an ICU kind of a setting, or it's like at least a high dependency unit kind of a setting, if this nursing is falling short, then the consideration in low resource setting would be that you supplement that with involvement of the family or carers in daily patient care. Right? I mean, in a high income country setting, probably it would be a 1:1 nursing ratio. But in a low middle income country setting, this is the low resource setting that can be done. Similarly, medical for all medical grades, we need to have at least 1 to 2 staff. And then there should be protocols of care to guide the nursing staff or the junior medical staff under supervision, who can again assist and help out where the staffing levels might be lower. Physiotherapy, also all grades, you need to have at least 1 to 2. Occupational therapy, at least 1. Speech and language therapist, at least 1. And ideally, a social worker should also be there. However, if they are not available, then these are roles which can be adopted by other staff. For example, nursing staff or physiotherapy staff. So speech and language pathologist, if you do not have an SLP at your center, then either the PT can take up that role, or the nursing nursing staff can be trained to do a swallow assessment. Same for social work as well. A nursing or a physiotherapy staff can be trained to take up the social work as well. Overall, we need to have a multidisciplinary team working, and once a week there needs to be multidisciplinary team meetings. Why? Because as all the team from multiple disciplines, like that is rehabilitation, nursing, medicine, as in the physician, they all need to get together, discuss the patient, and need to set and agree on treatment goals. Both short-term goals as well as long-term goals need to be decided. And another big important role of stroke unit care is involvement of the family. So family needs to be involved early on into the rehabilitation process as well, and also into the discharge planning. So at least by the third or fourth day, when the stroke patient is somewhat stabilized, then it becomes important that we start identifying that who is going to be the primary caregiver of the patient once this patient is going to be discharged. And that primary caregiver needs to be educated during ward rounds by the multidisciplinary team at multiple points in time. For example, if I'm a physician, I'm visiting, I should talk to the family carer, and educate them about what stroke is, what the secondary prevention goals are going to be, how long it will take for the patient to improve, and so on. Same from the nursing side, same from the rehabilitation side. And so that primary caregiver needs to be trained and involved into the whole improvement process, the rehabilitation process, and the recovery process of the patient. And also simple things like changing positions, giving sides in the bed, positioning of the arm and shoulder, those kinds of rehabilitation practices can also be taught to the primary caregiver. So involving the primary caregiver, making them more confident, and leading them towards the point of discharge is important. And these are things that as a multidisciplinary team, we in the stroke unit should be taking care of. Now, again, the concept of an MDT weekly meeting comes from high-income country settings. When, if you look at low resource settings, most of us are so overworked with clinical work that it may not be always possible to have that dedicated time aside. So one consideration that can be done in low resource setting is to incorporate this MDT meeting into the ward round routine. So you can decide maybe one day a week when the whole team comes together for rounds, you can like a grand rounds, and then everybody puts in their inputs, and these decisions, the MDT decisions, can be taken at bedside. So again, so that the whole team is unanimous on what the treatment goals for the patient are. And same thing with the involvement of the family and the caregivers as well. So if you look at, now this was a paper that was published in Lancet Regional Health Southeast Asia. So we looked at across Southeast Asia, mostly all low middle income countries across the region where the stroke burden is extremely high. We looked at the availability of neurologists and stroke units across the region. As you can see that very few stroke units, even in India where the number is around 400, but we're looking at a population of 1.4 billion. So you can imagine the ratio, how few stroke units we have compared to the number of the population that we're looking at. And similarly, at that time, the number of neurologists was 2,500. Maybe it would have increased by 500 or so now. But even then, we're looking at less than 0.01 neurologists per region or per patient, per 100,000 patients in these regions. So what I'm trying to say is that there will never be a situation where we have adequate number of neurologists, stroke units, facilities like IVT, EVT, PTs. If you look at the number of PTs, also very low. So we would never have a situation where probably that we would be able to match and a competent number of patients to neurologists and so on. And therefore, we need to look at maybe some alternative models of stroke care as well. This is another approach that should be taken into consideration for low resource settings. So this is another paper that we published in Lancet, and we looked at alternative models of stroke care. So because of the challenges that we face in LMICs, which are so unique, we need to have some adaptive models to kind of adapt to the various challenges that we have. One, of course, is the physician-led care, which I want to highlight over here. So the physician-led care means that you don't have enough neurologists, you don't have stroke physicians in the region, but you can train the physicians. Medical physicians can be trained, identify medical physicians who are interested in the towards the common goal of stroke care, and they can be trained in stroke care management, and they can be used to lead the stroke care management in that particular region. So we did something similar in this region called Tezpur, which is a very small remote region in the hilly areas in India, in the northeastern part of the country, and where physicians were trained. And we looked at the pre and post changes in outcomes, and there were significant changes in the length of hospital stay, the number of patients who received stroke unit care protocols. There was a reduction in the length of hospital stay, reduction in the mortality as well. So this has been proven to be a feasible model and a cost-effective model in low-resource settings. Another such model is the hub and spoke model. So if in a nearby region, you can identify a hub hospital which can provide some amount of comprehensive stroke care facilities, and you can link yourself to other spoke hospitals where these facilities are not available. Then again, the hub hospital can provide technical expertise, capacity building for the physicians in the spoke models, and also have kind of a shipping system, some kind of a system where patients can be identified who require comprehensive care and can be shipped to the hub hospital, and so on. So these are all some models which have been shown, alternative models of stroke care which have been shown to have benefit in low resource settings. Briefly about the types of stroke units. So different types of stroke units exist. This again comes from high income country settings. So the acute stroke unit or the acute intensive stroke unit is mainly where suspected stroke patients are admitted directly into the stroke unit, but these are just mainly for facilitating a rapid neurological assessment, adherence to the treatment protocols, and as soon as the patient is somewhat stabilized, these patients are quickly moved out of the acute stroke care. Here, the patients stay for a very short period, only around 3 to 7 days. The acute semi-intensive care system also is somewhat similar, where the hyperacute medical and nursing care is mainly looked at, and the rehabilitation part is not looked at. They're shifted out into a rehabilitation unit later. The other model is a comprehensive stroke unit model, where basically not just the acute part of the stroke is focused on, but even the post-acute part of the stroke, where the multidisciplinary rehabilitation, nursing, non-intensive management, and a little bit of early rehabilitation is also taken care of. And here the patient's stay would be longer, of course, because rehabilitation is also being integrated. And lastly is the rehabilitation stroke unit, where only the rehabilitation part is assessed. So the patient may have come from an acute or a semi-acute stroke unit and then shifted to the rehabilitation stroke unit, where the focus is primarily on the multidisciplinary rehabilitation. And these patients tend to stay much later till they are reintegrated back into the community. So to the main part of this talk, which is the stroke unit care protocols. So all stroke units should have established protocols and SOPs for how basic parameters and basic investigations need to be managed for stroke patients. So like I said, of course, every patient needs to have a CT or an MRI within 30 minutes of stroke unit care, of admission. Then we need to have some basic blood investigations like CBC, PT-INR, lipid profile. You need to look at the liver and the kidney functions. And then additionally, if you think patient needs a thyroid function profile, sugar management, sugar-related tests like HbA1c, those need to be done. With regards to stroke etiology, we need to look at an echo and a Holter, and we also need to look at the vascular structure. So either you can do a carotid Doppler if that is what is available in your hospital, or if you have the facility for CTA or MRA, then that should suffice. Special investigations, if it's a young stroke patient, or if you're suspecting alternative etiologies in that patient, then you need to look at certain other tests, like you need to look at hypercoagulable states, prothrombotic states. If you're suspecting vasculitis, given the scenario, then those things need to be addressed. And if a DSA can be done for those kind of patients, we need to have those separate protocols for different kinds of stroke patients. So very important is to understand blood pressure management in stroke patients. So mainly talking about ischemic stroke patients. So within the window period, that means patients who are eligible for thrombolysis or endovascular treatment. The goals of blood pressure are different compared to patients who are out of the window period, ischemic stroke patients again, where we are not planning on any kind of reperfusion therapy. So within the window period, if the patient is planned for thrombolysis or EVT, then prior to administering the IV thrombolysis, if the blood pressure is more than 185 systolic by more than 110 diastolic, then we need to bring it down to less than that. What I mean to say is the target BP should be less than 185 by 110 millimeters of mercury. And to achieve this, you can either give labetalol boluses, or you can start the patient on a labetalol infusion or a nicardipine infusion, and you can titrate the medication every 5 to 15 minutes by repeatedly checking blood pressure till the blood pressure has come down to less than 185 by 110. This is pre-thrombolysis in a patient who's eligible for thrombolysis. Once you've started giving the IV thrombolysis, or once the maintenance dose is going on, blood pressure needs to be checked every 15 minutes for 2 hours. Then you can bring it down to Q30 minutes for 6 hours, and then you can bring it down to Q1 hourly for the next 16 hours. And here the blood pressure target is less than 180 by 105. So 55 mg lower than what we saw there. And again, if the blood pressure is rising above this, you can go back to the same mechanisms. You can either give labetalol boluses or infusion, or if it's still not getting titrated, you can give nicardipine infusion. And if it's still not controlled, then you can consider sodium nitroprusside. So this is for window period stroke patients. Now, if you look at the non-window period ischemic stroke patients, there is no indication to aggressively target blood pressure. So permissive hypertension is actually recommended in these patients because we are not planning to reperfuse these patients. So if they have some kind of an occlusion, we want the blood pressure to ride high. It will help with reperfusing the brain and also help with reperfusing the brain through the collaterals. So in the initial acute period, when they have presented, we do not want any kind of aggressive blood pressure reduction measures. Only if the blood pressure is more than equal to 220 by 120 millimeters of mercury, then we can consider to give a small dose of labetalol or an oral medication or something, so as to bring the blood pressure down slightly. Otherwise, if let's say the blood pressure is 180 by 100, 190 by 100, we do not need to touch it. We can just let the blood pressure ride high. Over the next 24 hours, also what is recommended is that you lower the blood pressure only by 15%. So if the patient came with a blood pressure of, let's say, 200 by 100, then by the next day, we would hope to achieve something like around 180 by 90, something like that. And then gradually over the next few days, we try and bring it down to the normal blood pressure. We do not want that ischemic stroke patients should be rapidly brought, their blood pressure should be rapidly brought down. Calcium channel blockers, as a rule, should be avoided because they tend to cause hypotension. However, gradually as in how the requirement of the patient is. If a CCB needs to be introduced, it can be introduced later. The next protocol that is very essential in the stroke stroke unit management is known as the FES protocol. So FES stands for fever, sugar, and swallow. So these are three basic physiological abnormalities that can happen in any of our stroke patients who are admitted to the stroke unit. And all of them have been shown to be poor prognostic markers. So if a patient has fever, a patient with stroke has fever, it ends up in the releasing of excitotoxic amino acids. There is detrimental inflammatory response, and all of this adds to the poor functional outcomes from the stroke. And therefore, it is recommended that we actively seek out the source of infection, aggressively manage the patient with paracetamol at least regularly. You can give it TDS or Q6 hourly as per your protocols, so as to keep the patient afebrile. Every spike of fever adds to the poorer functional outcomes of the patient. Controlling fever or management of fever actively in the stroke unit has been shown to reduce death and dependency and has a beneficial effect on functional outcomes. Same with sugar. Both hypoglycemia and hyperglycemia are associated with poor outcome, regardless of whether the patient is a diabetic or not. But it has also been seen that if you very rigorously control glycemic control, it has also not shown to improve outcomes. And so what is recommended is that you keep it at a normal blood sugar range between 90 to 200 milligrams per deciliter. And lastly, swallow assessment. Swallow assessment is extremely important in stroke unit care. All patients with stroke should receive a swallow assessment within 24 to 48 hours of being admitted. Till the patient receives a swallow assessment, patient should be kept nil per orally by mouth. So even aspirin, if you need to give to the patient, it should be given only after a swallow assessment. If the patient fails swallow, then it is recommended either to keep the patient NPO or to start the patient or to keep the patient or to start the patient on an NG. So like RT feeds, or you need to insert an NG and then you can give the patient medications via NG. So swallow assessment all patients should receive. Why? Because there is a high incidence of aspiration pneumonia in all these patients with stroke, and therefore a formal swallow assessment should be done. Until a formal swallow assessment is not obtained, you can do a bedside swallow. The nurses can follow simple swallow protocols like the UK swallow protocol or the MGH swallow protocol. These are easily available protocols online, and you can train your nurses to give the swallow assessment to your patients. The evidence for this comes from this study, the CAUSE study by Sandy Middleton. She is a nurse who led this whole trial from Australia. And they saw that just by basic management of fever, sugar, and swallow assessment, like we mentioned, they were able to bring about a 15.7% reduction in death and disability at 90 days post-stroke. What they did is they decreased the mean temperature, improved the swallow screening, and the length of stay in the hospital was also reduced by 2 days. So this is a very, very effective yet simple protocol that can be immediately instituted and should be instituted in your stroke unit care. Then looking at intravenous fluids, preferably stroke patients should receive normal saline and not dextrose because of the osmotic pressure that is exerted by dextrose. And if the patient has not passed swallow or we're not able to do swallow, then continue patient to be on IV fluids and keep the patient NPO. Oxygen replacement, routine supplementation of oxygen is not recommended. However, if the patient has hypoxia or if the patient is drowsy or hypotensive, then it has been seen that oxygen replacement can actually help with some early neurological recovery. Then coming to complications. So post-stroke complications are very common, especially in patients who are staying for prolonged durations in the stroke unit. Pneumonia is one of the most common complications that happens with most of our stroke patients, especially the ones who have dysphagia. Who are not able to swallow. There might be some amount of aspiration that still happens even despite an NG. So it is recommended that the patient is kept in a semi-upright position. You need to have frequent suctioning. Chest physiotherapy needs to be instituted early, and formal swallow. Before you initiate oral fields or medications, a formal swallow needs to be done. If the patient does develop pneumonia, then early treatment with antibiotics is indicated. However, prophylactic antibiotics, just anticipating that the patient may go on to have pneumonia, is not beneficial, and it has not shown to prevent pneumonia as well. Then the other most dreaded complication with post-stroke patients is deep vein thrombosis and pulmonary embolism. These are both common complications, and all patients of stroke, whether ischemic or ICH, should be having DVT prophylaxis, especially if their lower limbs are weak, less than 3 power. They should be started on DVT prophylaxis. You can either give low molecular weight heparin, but there is a slight risk of increased hemorrhagic transformation with low molecular weight heparin. What the treatment of choice is intermittent pneumatic compression, or a combination of intermittent pneumatic compression plus low molecular weight heparin. Earlier, those TED stockings and graduated pressure stockings used to be used. Those are completely ineffective and are not recommended. Then urinary incontinence. Urinary incontinence can happen in up to 40 to 60% of stroke patients. We need to first identify what is the cause, if it is a UTI, or if it is because patient is not able to have inhibition because of the stroke itself. And in those patients, you can plan for regular toileting. UCAT should be avoided, internal UCAT, unless the patient is going into urinary retention, because it becomes a source for infections. Raised ICP, of course, if the patient has a large ischemic stroke, or if it's a posterior circulation stroke, or if it's an ICH in the posterior circulation, these are the patients who may have raised ICP. Again, recommendation to keep the head end elevated at around 15 to 30 degrees. Start the patient on mannitol or hypertonic saline. Any of these osmotic diuretics can be started. There is no role for steroids in these patients. And if the patient is intubated, then hyperventilation can also help to bring down the PCO2 by increasing the pH and decreasing the intravascular volume, and a subsequent drop in ICP can be seen in these patients. Now, coming to rehabilitation, multidisciplinary approach to rehabilitation of stroke patients is recommended, which means you need to have physiotherapy, speech therapy, occupational therapy on your team. Early goal setting is recommended. Short-term goals and long-term goals should be separately planned by the rehabilitation team. So short-term goals is within this much time, I want passive movement of the leg, or the patient to be at least sitting up with support and things like that. And long-term goals like, okay, within this much time, so and so needs to be achieved, that the patient may be able to walk with support or something like that. And again, early involvement of carers is extremely, extremely important. In the early rehabilitation phase, passive turning and mobilization has brought about a significant reduction in chest infection rates. And in rehabilitation, for the rehabilitation professionals here on the team, functional task training or task-related interventions are what has been shown to improve mobility and activities of daily living and reintegration back into the community. So there was the AVERT trial, which looked at when we need to start mobilizing our patients, because till the AVERT trial, there was no clear-cut guidelines on how early is early mobilization. So different practitioners were practicing different things. For example, some would start mobilizing within the first 24 hours itself. Some would be very delayed, wait on till beyond 48 hours. Some would start doing it between 24 to 48 hours. And so after this trial, we had some guidance that in fact, very early mobilization, that is less than 24 hours of stroke onset, if you start mobilizing, this is actually associated with harm, and there is a reduction in the odds of a favorable outcome, in fact. So the current guidelines, they recommend that after 24 hours, but within 48 hours. So it should be within the 24 to 48 hours period that we start early mobilization for our stroke patients. Then again, early discharge planning. So median length of stay for a patient after a stroke is around 7 days. Family and carers need to be fully involved in the discharge planning process. Discharge needs, recovery goals, where is this patient going to go back, what is the kind of setting that they have at home, if the patient stays on the ground floor, first floor, how are they going to take the patient, how is the patient, if the patient is walking, how far is the washroom for the patient, is there a railing, what is the fall risk assessment for these patients, are they at a, do they have a caregiver who will be taking care of these needs, or if the patient is bedridden or more dependent, who's going to be the caregiver, and what are the needs of the patient? Do they have a bed that can be lifted up 30 degrees? All these kinds of things need to be discussed before discharge for patients in our setting. There's a concept of early supported discharge, which basically means that a single specialist from the multidisciplinary team actually goes home and helps the patient with discharge, with rehabilitation. Even after going home, they visit the patient around 1 to 4 times up to 3 months, and this is actually shown to lead to better patient outcomes. If you are able to plan such a facility from your hospital, then that definitely that has some significant benefits. Otherwise, just a very close hand holding of your patients through supportive care and like clear goals that have been set with the patient and the carer can also substitute for this discharge planning. And then, of course, secondary prevention. I'm not going to go into the details of this, but yes, every patient on the stroke unit should have undergone a complete etiological evaluation so that we know what kind of stroke we are dealing with. If it is a large artery stroke, large artery atherosclerosis, or a small vessel atherosclerosis, is it cardioembolic or is it multifactorial? And if so, the correct antiplatelet or anticoagulation therapy has to be instituted based on what the stroke etiology is. And then risk factor control. So if the patient is hypertensive, diabetic, adequate management of those risk factors, dyslipidemia with statins, and so on. So to summarize, in the stroke unit care is a multidisciplinary assessment. There is a medical management, there's a nursing assessment and monitoring, and there's a treatment assessment that needs to be taken care of. In the first 5 days, which is the acute management, you are looking at the basic physiological management, managing complications, early mobilization, and acute nursing care. All of these together are essential to the acute management. And then beyond the acute, the post-acute part of stroke care is predominantly a rehabilitation team driven, where again, it's a multidisciplinary teamwork. Nursing can link with rehabilitation. You need to have early goal setting and early involvement of carers. And discharge planning, again, early assessment of what the discharge needs are, and to plan with the patient and the carers what do they expect, what their expectations out of the current event is, and where do they see themselves in the next few days or the next few weeks. Thank you.
Thank you, Madam, for this informative lecture. It's really great. Then we move to the Q&A section with Dr. Ola and Dr. Mardin. The word is yours, Dr. Mardin.
Thank you, Dr. Ivy Sebastian, for the nice lecture. So now we will move to the questions by the audience. The first question is from Dr. Mustafa. So he asks, if we establish small stroke units that cannot include all acute stroke cases, who would be put on priority to admit?
So you mean that if it's a small stroke unit and not all acute stroke patients can be admitted? So I would say it depends on what type of stroke unit you are able to set up. If it is a stroke unit that is capable of managing the sick patients or ventilator associated patients or with respiratory discomfort and so on, then you can probably target to keep 2 or 3 very sick patients in that stroke unit, and the lesser sick patients in your outside ward, or not the high dependency stroke unit. On the other hand, if you think that you do not have the facility to manage that and you would rather admit those patients into your ICU, then you can have just your moderately affected stroke patients who may not require intensive monitoring. Those are the patients that you can keep. It all depends upon what type of stroke unit you are ultimately going to set up in your place. To give an example, in our stroke unit, we have 8 to 9 beds identified for the very sick patients. That's the proper stroke unit. And then we have like a step down unit where your lesser sick patients are kept. So even from the ICU setup, the stroke unit ICU setup to the lesser step down, we have another 2 or 3 beds, which are just monitored beds, but they may not have all the intensive monitoring. And then we have like a ward set up for the other 10, 20 patients, where normal other stroke patients, along with some neurology cases, can also be kept in different areas.
Okay, the next question is from me. So the guidelines recommend frequent blood pressure measurement and neurological assessment, like you mentioned, every 15 minutes in the first 2 hours in thrombolyzed patients. So is there any standard protocol on what neurological assessment must include for cases who have been thrombolyzed?
Yeah. So for neurological assessment, what is usually done just at baseline, as soon as you admit a patient or when you see the patient in the emergency, of course, we can do a detailed neurological examination, but mostly what is done is the NIHSS scale, which I'm sure all of you must be aware of. So it's a rapid, quick assessment of the entire neuro axis consisting of these 11 points. So the NIHSS can be the scale that can be done at every frequent 1 hour or 2 hours, especially in the acute, hyperacute stroke patients. We recommend that an NIHSS is done at admission, then an NIHSS in the thrombolysis patients has to be done at 24 hours or at any point before. If the patient shows any signs of clinical worsening, then you need to have a documentation for NIHSS. And then again at 7 days or at discharge, whichever is earlier. So these at least 4 time points of NIHSS must be there. This is maybe from physicians. Nurses also can be trained in doing NIHSS, and they should also be, at least the stroke nurses in your unit should be certified in NIHSS. This is a free online tool which is available. So all the entire team in the stroke unit can get certified with NIHSS. So it really helps do that. But for a rapid neurological assessment from the nurses, maybe just an initial GCS scoring can also be done, or what they call the neuro check. It's like a multiple modalities. They look at basic GCS monitoring. They look at any eye changes, pupil changes, any gross abnormalities, and they also look at any vitals which have changed. So you can adopt any of these protocols. Yeah.
Thank you. The next question we have is from Dr. Qatr. She asks, what is the role of Diamox tab in elevated ICP? Diamox is acetazolamide.
What is the role of diamoxin?
In raised intracranial pressure.
Okay. We can use diamox. It depends center to center. We do not particularly use diamox in acute arterial stroke patients, although there is definite evidence in venous stroke patients. So CVT patients, definitely a lot of centers use acetazolamide in kind of like a preventive measurement for raised ICP. In arterial stroke, not much of acetazolamide has been studied. I don't think there is much evidence, but there may be a few centers which kind of extrapolate the evidence from venous strokes to arterial strokes and use it. There is no harm. You can use it, but preferably in arterial strokes, what is still recommended is mannitol or 3% saline. If you actually look at the literature, there is no evidence for even mannitol as well. The only evidence that is available is for hypertonic saline, and that too, it is for 20% hypertonic saline. But many places this is not available, and that is why people still tend to use mannitol and hypertonic 3% saline. The only recommendation for these raised ICP measures with osmotic diuretics is also in patients who are awaiting surgery. For example, if you have a malignant MCA infarction patient who you know is going to go for a decompressive hemicraniectomy, in that group of patients for 1 or 2 days, you can definitely use mannitol or 3% saline. Otherwise, prophylactically just or empirically starting all your patients on mannitol or 3% is not really, there is no evidence behind it. But having said that, many centers use it. We also use it, as in when we feel if the patient has a lot of edema, especially ICH patients, if there is a lot of perihematomal edema, we tend to use it.
Thank you. So we have another question from Dr. Qatr. She asks, decompressive hemicraniectomy improve survival or does it reduce the mortality, and what is your experience with it?
Yes, so that's a very important question. Decompressive hemicraniectomy, definitely there are certain indications like your malignant MCA infarction, then your posterior circulation strokes, large strokes with so posterior decompressive hemicraniectomy is indicated. The thing is the main issue, there are multiple studies. We have the 3 trials actually, Decimal, Hamlet, and I think Destiny. 3 trials which have shown that yes, definitely there is improved survival and reduced mortality with decompressive craniectomy. But the issue is patient selection. Very elderly patients, it has not shown much benefit. But also very elderly patients usually have enough cerebral atrophy, so they may not go on to a point to require decompression because the atrophy itself may accommodate for the cerebral edema which is there. Younger patients, large strokes, posterior circulation strokes, even with little bit of midline shift, early identification of these patients and early decompression is recommended, and that has definitely shown to improve survival.
Thank you. Our next question is from Dr. Mustafa. He asks for bedsore prevention. Is there any evidence supporting the use of pneumatic beds or mattress?
Of course. I mean, I don't know. I don't know well enough to support cite literature on pneumatic bed or mattress, but we use it for all our patients because, of course, all these patients, bedsore is another complication I did not mention in my slides. But bed sores is another very common complication that most of our stroke patients tend to have. So frequent positioning, change of position, pneumatic bed or mattress, air mattress or water mattress can be used in these patients. And we use it in all our patients with stroke.
Thank you. We have one more question from Iqbal Haider. The question is there any recommendation for head position for stroke patients?
Yes. So it is, like I mentioned in my slides, it is recommended to keep the patient's head slightly elevated around 15 to 30 degrees. We don't want to keep our head positions completely flat. There are multiple reasons for that. One is, of course, you can prevent a little bit of aspiration pneumonia in these patients. Second is, if you are anticipating raised ICP, then this head position helps to reduce the raised ICP as well. There were a few studies. Our center was also part of the head post study, which actually tended to look at if there is a difference in change of head position with outcomes. And that study was actually neutral. It did not show any difference. But still, mostly it is recommended that at least a 15-degree head elevation should be given for your stroke patients.
No more questions. Thank you very much. So we go back to Dr. Qatr.
Thank you, Dr. Mardin. Thank you for all the contributors for waiting at the end of this meeting. We remind you to follow us on social media and to join our network if you haven't yet. We are open to hear from you to develop our work, and we are looking forward to meet you at the next meeting. Last and not least, we want to thank Abdulkareem Pharma for supporting this webinar, and have a good night. Thank you.
Thank you. Thank you, everyone. Thank you so much.
Thank you. Thank you very much, Dr. Sebastian.
Thank you so much, Mustafa, for inviting me. And it is really good to make all of your acquaintance. And yeah, thank you so much for your patient listening.
Thank you. It was our honor to have you. Bye.
Bye. Good night.
Good night.
Thank you, everyone.